Hello friends, in this series of sleep medicine, we will discuss about polysomnography in this lecture. I have made this video in Hindi language also. So let's see further slides. So in this lecture, I have included about introduction of polysomnography, that is called sleep study, type of polysomnography, various sensor used for sleep study, what are the sensor which is giving various data in sleep medicine, indications of sleep study, contraindication of sleep study, and I'll discuss about few new devices which are there for sleep study. Then after this lecture, I'll discuss 5 cases and I'll ask question and you have to answer me. So I'll not include in this lecture is hooking. So this is my next lecture. I'm going to prepare next lecture on hooking of various leads and sensors in polysomnography. Sleep study scoring, this is another lecture. How to interpret sleep study, I have uploaded video in my YouTube channel, you can see. About titration, I'll make separate video. So introduction, first we have to differentiate between polygraphy and polysomnography. So in polygraphy means, as name suggests, poly means multiple, graphy means recording. If we are recording multiple channels, multiple parameters, this is called polygraphy. If we are recording multiple channels while sleeping, sleepy means somno. It has three components: poly, somnography. Multiple, somno means sleep, graphy means recording. If you are recording multiple things in sleep phase, then this is called polysomnography. So this is difference between polygraphy and polysomnography. So first question is how to suspect patient as a obstructive sleep apnea. So we have to do screening. Once you do screen, then only you can prescribe sleep study for that particular patient. So how to do screening? We have to ask these 8 questions to ourselves and to patient. And we have to calculate how many risk factors are there in that particular patient. These are stop bang scoring model. These are snoring. Snoring means loud snoring. Okay. Tiredness, observed apnea. You have to ask that patient spouse while sleeping, he is getting up during sleep. So this is observed apnea. Blood pressure, whether patient is hypertensive or not. High BMI, patient is obese. BMI more than 35. Age, older age, more than 50 years. This is also risk factor. Neck circumference, more than 40 centimeter. Gender, male gender. So out of these 8 questions, if you find answer for 3 or more items, then that patient is suspect for obstructive sleep apnea. In that patient, we have to advise sleep study for confirmation of OSA. If score is 3 or less than 3, then we should not advise sleep study. So this is about screening. Now we have to understand what are the indications for sleep study, polysomnography. Okay. Of course, diagnostic sleep related breathing disorder. What are they? Like obstructive sleep apnea, obesity, hypoventilation syndrome. Okay. Like central sleep apnea. So these are the sleep related breathing disorder. Then preoperative PSG. So those patients who are having symptoms of OSA or already diagnosed case of OSA, in them, if you are planning surgery, then we have to do preoperative polysomnography to rule out obstructive sleep apnea. Because if you do not treat OSA prior to surgery, these patients will have more chance of post-operative complications. So before surgery, we have to do polysomnography and we have to start treatment prior to surgery. When to do repeat diagnostic PSG means if patient is already diagnosed case of OSA and you want to repeat. When to repeat? If patient is having suspicious of OSA, like patient is obese, hypertensive, male patient. If patient is highly suspicious of OSA and your polysomnography report is negative, then you have to repeat polysomnography for diagnosis purpose. If patient has gained 10% of weight or lost 10% of gain already on CPAP. Say for example, if patient is having severe OSA or moderate OSA and you are giving CPAP therapy. So after CPAP therapy, if patient lost 10% weight or gained 10% weight, so that particular patient will require either high pressure or more pressure. The pressure requirement would have changed. So for pressure change, we need to do repeat sleep study to give him correct pressure. Okay, say for example, if somebody patient requiring 16 centimeter water pressure requirement, he has lost 10% of weight. So his pressure requirement might be lower than that of which were prescribed. Means it will be lower than 16. It may be 12, 13, we don't know. So for correct pressure, we have to repeat polysomnography. Then those patients of obstructive sleep apnea in whom we are giving not PEP treatment, like surgery patient. Okay, say for example, bariatric surgery, that patient. Okay, so after bariatric surgery, after 3 to 6 months, we have to repeat polysomnography to see whether his problem of OSA has gone or not. We have to do after 3 to 6 months. If patient had surgery and OSA was maintained, means controlled, but after some time, if symptoms return, then we have to do polysomnography to diagnose whether his AHI has increased or not. If patient is applying oral appliances, okay, in them we have to do sleep study along with oral appliances, so we can demonstrate whether oral appliance is sufficient for him or not. If on OA treatment, patient is having treatment with the oral appliances and symptoms return, then we have to do repeat polysomnography to say whether he is having OSA or not. His OSA is controlled or not with oral appliances. So these are the condition we have to do polysomnography. Important thing is where not to do polysomnography. Indication we know, but we should know when not to do. If patient is doing well on CPAP therapy. See for example, if you're diagnosed OSA patient, you have prescribed CPAP and he is doing very well on CPAP. In that patient, no need to repeat polysomnography. If patient is happy with CPAP. Okay. Evaluation of asthma chronic lung disease unless OSA is suspected. Patient, lot of COPD patients are there. If you are suspecting OSA by stop bang questionnaire, then only you have to do polysomnography. If you are not suspecting or patient doesn't have any OSA symptom, no need to do sleep study. Routine evaluation of insomnia, no need to do polysomnography. Treatment of restless leg syndrome. So in that, no need to do polysomnography. If you are suspecting periodic movement disorder, then you have to do sleep study. Evaluation of depression. Psychiatric evaluation is more than enough. We don't require to do polysomnography. Uncomplicated parasomnia like sleepwalking, wetting. In these patients, clinical diagnosis is sufficient. No need to do polysomnography. Evaluation of circadian rhythm sleep wake disorder. Late sleeping, late night sleeping, late wakening. These are circadian breathing disorder, sleep wake disorder. No need to do polysomnography. Just maintaining sleep diary, we can diagnose this disease. Now, if you are doing sleep study, what are the things you are expecting from sleep study? What parameters sleep study should tell? Okay, so in sleep study, we can find sleep architecture. Means when patient is sleeping, what is the sleep latency? You are that giving sleep. You are doing sleep study, and after switching on sleep study, when patient getting actual sleep, that is sleep latency, sleep efficiency. Then either patient whether patient is having deep sleep or superficial sleep, whether non-REM sleep or REM sleep. These parameters can be find out by level 1 or type 1 study. I'll discuss later. So sleep architecture, we can see these parameters. Respiratory parameters, which is very important to diagnose obstructive sleep apnea or obesity, like apnea, hypopnea. Apnea means just complete cessation of airflow. There's no airflow going inside the body. Hypopnea, 30% reduction. So we have to identify by the help of sleep study. Snoring, oxygen saturation. Because whenever patient is having apnea, hypopnea, there is reduction in airflow. It will reduce uh, uh, oxygen saturation, SpO2. So in sleep study, we can see oxygen saturation, how much patient is getting desaturation, minimum SpO2, SpO2 below 90%. So these are all I have included in sleep report interpretation. You can check my YouTube channel. You will find individual parameters I have discussed there. Now, heart rate parameters like heart rate maximum minimum, arrhythmias, blood pressure variability. Because whenever patient is having OSA and having episode of apnea hypopnea, they will have cardiac problem also because of chronic hypoxemia and sympathetic surge. So these parameters we can find by sleep study. Then arousals. Okay, arousals while patient is sleeping, or in fact normal patient is sleeping, normal individual is sleeping, at night time he is having many arousals. Okay, arousals is so brief, like 3 second, 4 second, 5 second. Patient doesn't know that he is having arousal. By sleep study only you can identify that patient is having lot of arousals which can cause daytime sleepiness. These are the parameters we can find with sleep study. Then last is video recording and electromyogram. So by sleep study we can find out periodic leg movement, and by videography we can identify various parasomnias like sleep talking, sleepwalking, REM behavior disorder, any seizure disorder like that. So these all parameters we can find out by sleep study or polysomnography. These are the maximum parameters. So for measurement of these parameters, we required recording devices. We are required sensors so that we can record everything. Okay. For sleep parameters like latency, sleep efficiency, REM sleep, non-REM sleep, we require these three channels: EEG, electrooculogram EOG, and chin electromyogram EMG. Okay, airflow signals, respiratory effort beds, oxygen saturation. These are for respiratory events. Airflow signals I'll tell in brief. Then CO2 sensor. This is optional. In every patient we are not using. For few patient, especially pediatric patient, this is mandatory CO2 sensor. For heart rate parameters, we have ECG. You all must have seen ECG. So by ECG, we are measuring all these heart parameters. EMG, periodic leg movement. And by video, we can identify parasomnia. So these are the sensor or electrodes we required for sleep study, complete sleep study. Okay. So I'll tell you these sensors in brief. Okay. First, we are attaching EEG, electroencephalogram. Okay. So we have to see at least three lead, one from frontal F4 or central C4 or occipital C2. And these are the backup leads. Along with these three leads, we have to attach lead on mastoid. Okay, so why three leads are required at least? Because when patient is sleeping, he is generating various frequency wave. You must have heard in your MBBS days, like in sleep, in while sleeping, there is beta wave, alpha wave, delta wave, theta wave. So every wave has special characteristics which can be identified in particular lead. Okay, like slow waves, or also called delta waves, which is well appreciated in frontal lead F4. Some spindles, which is characteristics for N2 sleep. This is seen more prominent in central lead C4. Alpha rhythm, best lead is hospital leads. So every wave has some characteristic feature which can be appreciated in particular lead. That's why we are using three leads minimum. Okay, with reference to mastoid. So why reference is required, I'll tell you in while I'll I'll show you hookings in next lecture. Okay, so three stages for staging of sleep, but these three leads are not sufficient. We have to see electrooculogram EOG, because you must have heard that there are two parts of sleep. One is rapid eye movement sleep, another is non-rapid eye movement sleep. Rapid eye movement sleep, as name suggests, it has rapid eye movement. So for rapid eye movement, we have to do EOG, electrooculogram. So in electrooculogram, if you find rapid eye movement, it means REM sleep. If you find slow eye movement, this is non-REM sleep. So for differentiation of non-REM versus REM, we have to do EOG. Another is we have to do chin EMG, electromyogram for chin, because in REM sleep there is hypotonia of muscle. So hypotonia, there is loss of muscle tone. So we are measuring chin movement or chin tone. If muscle tone is intact, it means there's non-rapid eye movement sleep. If chin tone is lost, then this is REM sleep. So to differentiate REM between non-REM, we need EOG, we need chin EMG. So for sleep parameters, we need EEG, EOG, EMG. Okay. For this is example. In this, you can find this K complex. This is sleep spindle. This is N2 sleep of non-REM sleep. And in this, you can find this. This is EOG. You can find rapid eye movement. So don't worry. I'll tell in that if when I'll tell lecture in scoring, how to score sleep, how to score apnea, hypopnea. In that I'll discuss in detail. But in this, you can find rapid eye movement. This is REM sleep. Okay. Now coming to respiratory parameters. Respiratory parameters, we are bothered about whether apnea is there, whether hypopnea is there. Okay. For measurement of apnea and hypopnea, what is apnea? There's reduction in flow. Okay. So we need two sensors. One is specific for apnea, another specific for hypopnea. For apnea, we are using thermal device, or also called thermistor, oronasal thermistor, because it it is detecting airflow, nose and mouth. So oronasal thermistor, it work on principle of temperature difference. We are inhaling cold air, exhaling warm air, so there is temperature difference. This temperature difference is measured by this thermal device, thermistor. If temperature difference is there, it will tell there's temperature difference. It means airway is patent. If there's no temperature difference, it means there is absence of airflow. So by that, it detect apnea. Okay. Another is pressure transducer, also called nasal cannula. It is looks similar like a nasal cannula we are giving for oxygen therapy. Okay, so it is detecting airflow, how much airflow is going in, how much airflow is coming out. Okay, so by airflow measurement, it detecting hypopneas. So pressure transducer is specific for hypopnea, thermal device is specific for apnea. But we are using both devices. So if one is non-functional, another one will detect as a backup. We are using both devices. So in this you can see there is complete reduction of airflow. This is in oronasal thermistor. So oronasal thermistor is specific for apnea. This is apnea. And this is hypopnea. This is measured by pressure, nasal pressure transducer. This is hypopnea. Okay. So another thing is whether our apnea is central apnea or obstructive apnea. For that, we have to look for chest movement and abdominal movement. If there is apnea along with absence of chest movement or abdominal movement, then that is central apnea. Because whenever there is obstruction while taking air, means apnea or hypopnea, the chest movement or abdominal muscles should work. There should be movement in chest and abdomen. So for detection of chest movement and abdominal movement, we need chest belt. It's also called RIP, RIP, not rest in peace. This is respiratory inductive plethysmography. So it is detecting chest movement and abdominal movement for whether obstruction or central apnea. So in this diagram, you can see there is apnea by nasal pressure and oronasal thermistor apnea. Along with apnea, there is presence of chest movement and abdomen movement. So this is obstructive apnea. In this, there is apnea, chest movement and abdominal movement is also absent. This is central apnea. This is mixed. First there is central, then obstruction. This is mixed apnea. So by this we can identify this respiratory parameters. Another is very important, oxygen saturation. Because in apnea hypopnea there is reduction in SpO2. So for SpO2, we are using pulse oximeter. It is detecting baseline SpO2, minimum SpO2, hypoxia burden, all these things. So my question is to you, this is looks like same as what we are using in ICU or general ward. So can we use ICU pulse oximeter or portable pulse oximeter for sleep purpose like this one? Answer is no, big no. Why? Because these pulse oximeter have large sampling rate. It means once it will detect SpO2, it will give next reading after 5 to 15 minutes only. But as you know that apnea, hypopnea is for 10 seconds. Okay. So if anything happens in 10 or 15 seconds, this pulse oximeter will not detect low saturation or change in saturation. So for that, we need a pulse oximeter which can detect change in SpO2 within 3 to 5 seconds. So for that, we are using different pulse oximeter which has low sampling rate. Means it can detect change in SpO2 within 3 to 5 seconds. Okay, so that's why we are using separate pulse oximeter. Now this is snoring microphone for detection of snoring. So snore from where it is coming is from vocal cord. So this is a sensor we have to stick on little part of larynx. So it can detect snoring. CO2 sensor, this is two type. One is transcutaneous PCO2 and this is end-tidal PCO2. So this is not used frequently, but remember in pediatric patient we have to use. This is mandatory for pediatric patient. This is CO2 sensor. Then about heart rate or arrhythmias. For that we are using ECG, two electrode. It is telling heart rate variability and arrhythmias. And last is PLM EMG, periodic limb movement. We have to stick two electrode on anterior tibialis muscle. This is anti-tibialis muscle. So it will tell about leg movement. And there are criteria to see PLM. I'll discuss in the scoring part. But for that, we have to record electromyogram from anti-tibialis muscle. So based on these sensors, how many sensors you are using in your patient? So based on these sensor, number of sensors used, sleep study is divided into four types: type 1, type 2, type 3, type 4. Okay. So I'll tell you individually what is type 1, type 2, type 3, and type 4. So type 1 polysomnography, we are seeing four parameters: sleep parameters, cardiorespiratory parameters, and movement. Another thing is it is being done in hospital only. So there is dedicated technician who is observing patient whole night. So there is video recording of that patient. Okay. So this is gold standard because it is using all channels which I have uh, described in previous slides. Gold standard. So it can find to find out any sleep related breathing disorder. Used for titus study, sleep night study, parasomnias like narcolepsy, insomnia, parasomnias is a disorder. So any type of sleep disorder you can identify in type 1 study which is being done in hospital in presence of trained technician. These are the channels or signals we are using in this type of study. These are the various devices. Level 1, this is from Cardwell company. This is from Somnomedis, and this is from Philips. So these are various devices. Now type 2. Type 2 is same as type 1. Only difference is it is being done in home. Type 1 was done in hospital. Type 2 is being done in home basis. If it is being done in home, there is no supervision. There is no technician. Technician will go and will attach all leads, but it will not stay. He will not stay. So this is unattended portable monitoring, and there's no videography. So this is used at home. So all things are there. There is no video recording and there is no technician. This is two. This is most commonly used type 3 sleep study. In this study, there is no sleep parameters. There is no sleep latency. There is no REM sleep. There is no non-REM sleep. There is no sleep architecture. So we can see cardiorespiratory things. Respiratory means apnea, hypopnea, oxygen saturation, and cardio means pulse rate variability. We can use ECG also. And leg movement is optional. So there's limited parameters, but is sufficient to diagnose obstructive sleep apnea. Okay, so there is no EEG, there is no EOG, there is no EMG because there's no sleep parameters and there is no video recording. This is type 3. So this is the type 3 devices, the small devices. See, this is small devices, so patient is very comfortable while doing these sleep studies. Okay, type 4 is just screening purpose. Only one or two channels. One is pulse oximeter. Another is you can tie belt also to say whether patient is having apnea or hypopnea. So this is for screening purpose only. Type 4. So I'll tell you one interesting story. This is real story. Okay. So this lady is 55-year-old female. She was having fracture neck of femur. He was hospitalized. And and then the interesting thing is when she was sleeping, there is dipping of her oxygen saturation. And she is her mother. She was very caring. So she was watching continuously at the monitor whole night, and whenever patient was sleeping his saturation was falling down. She went to staff nurse to wake her and tell that saturation is going down. So whole night she didn't sleep, and staff also didn't sleep. Okay, very interesting, because at night saturation was falling. So another day we got reference from this patient that oxygen saturation is getting fall at night while sleeping. So what is this? This is type 4 sleep study. Okay. So patient is overweight, patient is having low oxygen saturation at night. Probably patient may have obstructive sleep apnea. So we have to do type 1 or type 3 sleep study for further diagnosis. So in this patient, pulse oximeter was type of type 4 sleep study screening. Okay, so this is story. Another case is, this is also a real case scenario. Picture is not real, but case scenario is real. He was having overweight man of 50-year-old male. He was having hypertension, diabetes, and it was uncontrolled despite drug. He met an accident or road traffic accident, brought to emergency. After stabilization, he gave history suggestive of obstructive sleep apnea, like daytime sleepiness, snoring, fatigue. All these symptoms he has given. He had underwent angioplasty also for myocardial infarction. So this is the typical case of OSA. So OSA patient, they used to have multiple comorbidities, uncontrolled road traffic accident. In this patient, you should suspect OSA, obstructive sleep apnea. So my question to you is, which type of sleep study indicated in this patient? So remember, this type of patient, when comorbidity is there, when patient met an accident, you have to do type 1 study only. Okay, so this is guideline from American Academy of Sleep Medicine. So diagnosis of OSA in adult with comorbid conditions. So what this paper says, or this guideline says, we have to we recommend polysomnography type 1, then home sleep testing, apnea testing in patient those who have cardiorespiratory disease like congestive heart failure, COPD, or pulmonary hypertension. Means if patient is having comorbidity, then we have to do type 1 study only. Those patients who have respiratory muscle weakness due to neuromuscular condition, awake hypoventilation or suspicious of sleep-related hypoventilation, chronic opioid medication, history of stroke, or severe insomnia. So if patient is having any one of these criteria, we have to advise type 1 study only. This is the strong recommendation, not weak recommendation, strong recommendation. So remember, if patient is having comorbidity, we have to do type 1 study only, not type 3. Right? So why type 1 study in comorbidity? Because these patients, those who are having comorbidity like COPD, congestive heart failure, all these patients, they may have oxygen desaturation and arousal, which is independent of apnea, hypopnea. Means this patient can have this problem even without OSA, which we can find by full PSG only. Okay, and as I told you that type 1 study is being done by trained technician. If anything happening to patient like arrhythmia, okay, severe oxygen desaturation, then technician can watch and intervene immediately, because this is observed sleep testing. Okay, type 1 study. Another thing is that these patients are sick, they cannot come again and again. So we have to titrate adequately, accurately. So we can do titration study with CPAP and BiPAP on same day also. That's called split night study. Okay. So in these patient, only answer is type 1 study. So what is split night study? We know that everyone is busy in their life. So if you advise somebody that you have to come two times. One is for study, one is for titration. He may be absent. So in this study, what we can do that if we divide night in two parts, first half we have to do diagnostic study. In second half we have to do titration study. So what is the guideline says? Speed study is an old guideline, 2005 guideline. If patient is having AHI more than 40 during 2 hours of study, then we can go for speed night study. Or if patient is having 20 to 40 AHI but having long apnea CV desaturation, then we can go for speed night study. But mind you, that patient should have 3 hours remains for PEP titration in second half of night. Recent guideline 2017 says even if patient is having moderate to severe degree of OSA for 2 hours, and if patient is having 3 hours available for titration, in these type of patient we can go for split night study. But remember, while titration, patients should have REM sleep and supine position sleep, because as we know that maximum apnea hypopnea comes in supine position and REM sleep. If patient is not slept in REM or supine position, then titration which is being done without supine and REM, it will be inadequate titration, and we have to repeat in another day. So just remember, if you are considered for split night study, in titration part, patient should sleep in REM sleep and supine position along with normal sleep. But there are drawback, though it is gold standard sleep study level 1 or type 1, but there are drawbacks also. It is costly because we required we required this type of setup for sleep study. This is American Standard Sleep Center. Patient should have vent, the bed. Patient should have well aerated room, attached latrine bathroom. So this is very costly. Okay, and as I am making video, I am spreading lot of awareness to patient. There are lot of patient who are coming up for diagnosis of OSA. So level 1 study or hospital based study cannot get a large population, so we need type 3 study which can be done at home setup. Uncomfortable with so many sensors. You can see this lady, there are many sensors: EEG, ECG, nasal oxygen, all. So lot of sensor which is uncomfortable with this patient, and patient may require attendant, especially female patient or child patient. So two persons are coming for one patient study. Okay, this is which is not good. First night effect. You must have heard that, oh, I couldn't get sleep at hospital. I am very comfortable to my bed, but I cannot sleep at home or any other place. This is called first night effect. So patient, those who are coming first time to hospital for sleep study, they may not have adequate sleep, less sleep, and less REM sleep. This is first night effect. This is problem with level 1 study. So for these, there are study which is called type 3 study, which is home based study, also called portable monitoring devices, or home sleep testing, or out of sleep center study. These are all same. This is type 3 study. So this is question for you: which parameters lacking in type 3 study, whether sleep parameters or apnea or saturation, or we can see all. So as I told you earlier, we cannot see sleep parameters because we are not using EEG, EOG, EMG. Okay, sleep parameter we cannot see. So why this is good? What is the benefit of type 3 study? Because some patient of sleep apnea cannot be taken to sleep laboratory because of safety, or patient is not mobile, or patient is very anxious. So in that patient we can go for type 3 study. Or as I told you that there are a lot of awareness, so there are large population who are having OSA. We cannot do level 1 study in all patients. Okay, so this is cheaper. because we are doing at home. This is cheaper. So since sleep data is absent, as I told you, we cannot identify sleep latency, VASO, wake after sleep onset. We cannot identify whether it will lead to underscoring or overscoring of OSA. It will tell less HI or more HI as compared to actual AHI. This is a question for you. So think. So as I told you that without sleep parameters, we cannot find out arousals. Arousals, we can find it with EEG channel only. So as there is no sleep parameters, we cannot find arousals. Okay. So if you remember definition of hypopnea, this is flow reduction along with either 3% reduction in SpO2 or with arousals. So hypopnea contain arousals also. But with this study, with type 3 study, we cannot find arousals. Okay. So there are many hypopnea which is defined by arousals only. So it will give falsely low of hypopnea. Okay. Say for example, this patient is having 40 arousals actually, 40 hypopnea actually, but this machine will tell 30, 25. It will tell less because there is no arousal. Another thing is that total sleep hours. We don't have EEG, so we cannot tell what is the actual sleep onset when patient is wake up at night. How many hours patient slept? How many arousals were there? We don't know. So we are taking recording time as a total sleep time. This is the time when we started the machine. This is the time when we switched off the machine. We are taking whole recording time as a sleep time. So sleep time is falsely more. Arousal is less. Hypopnea is less. Sleep time is more. So you can see what is EHI, number of respiratory events, which is falsely low, divided by total sleep time, which is falsely high. So what will be the result? EHI will be falsely low. Okay. So type 3 study will underscore the OS. It will tell less EHI as compared to actual EHI. So since there is no sleep parameters, so we cannot identify arousals, right? We cannot identify hypopnea correctly. So instead of using EHI, instead of using apnea hypopnea, we are using respiratory event index. There is event, there is either apnea or hypopnea, but we are not able to define hypopnea. So the term uses respiratory event index rather than EHI, right? So it will falsely say that patient is having low EHI, right? So if patient is having severe OSA, then okay. Say for example, if patient is having EHI of 80, then this machine will tell okay, EHI is 70 or 60, again falling in severe category. If patient is having EHI, say for example 50, this machine will tell EHI is 40 or 35, still it is high. Okay. If EHI actually is 15 or 20, this machine will tell EHI is 10 or 5. So actual patient was having moderate OSA, but this machine is telling either normal or mild, which is not getting treatment, not going to get treatment because we don't treat mild or no OSA. Okay. So we have to do type 3 study only in those patients who are having moderate to severe OSA only. Okay. So this is American Academy of Sleep Medicine recommendation for home sleep apnea testing. So it is should be used for those patients who are uncomplicated and having sign symptoms that suggest moderate to severe OSA. This is strong recommendation. How to identify moderate to severe OSA? Those patients who are having excessive daytime sleepiness with two of following: either habitual loud snoring, witness apnea, or hypertension. If this criteria is getting fulfilled, then we can go for type 3 study or home based sleep study. right? So after home-based sleep study, how to do titration? There are many things, many ways we can do titration. Either without titration, we can provide autopay, or for titration, we have to do titration with autopay. Later on, we can prescribe same pressure in CPAP, or we can give empirical CPAP, depends on your experience. So you can give pressure of 8 or 10 or 12 based on your experience, clinical judgment. Or you can subject to hospital based titration, or there is no PAP treatment. So this is titration. So I'll take separate class for titration. So benefit of type 3 studies, as I told you, it is very comfortable for patient because patient sleeping their home on their bed. But we should do study when there is high p-test possibility of OSA, or we can do when there is planned surgery for snoring or OSA. For moderate to severe OSA, for to document effectiveness of oral appliances, for surgical treatment, dental treatment, if symptoms reoccur. So in this type of study, in this type of scenario, we can go for type 3 study or home-based study. So this is about type 3 study. Now coming to newer devices for home sleep apnea testing. This is type 3 study or type 4 study. This is newer devices. So first is watch PET. PET means peripheral arterial tonometry. This is the principal peripheral arterial tonometry by which this machine is working. This is developed by Israel by this Itamar Medical this company. So this is very small machine. This is like a watch, okay, and it has pulse oximeter like sensor. Okay, so this is PET. This is called PET machine, single PET machine with oximeter probe. Another another sensor is this one, chest sensor. This is chest sensor. This is based on suprasternal notch. This is suprasternal notch. Okay, so it will tell about snoring, body position, and detect chest movement. So by detecting chest movement, it will tell whether apnea is central or obstructive. Okay, so how it is working, I'll tell you. So whenever there is respiratory event, whenever there is apnea or hypopnea, okay, so after cessation of apnea, after completing apnea, there is arousal, or as there is apnea, when the apnea is getting terminated, there is sympathetic surge, there's increase in sympathetic activity. When sympathetic activity is getting increased, there is more secretion of adrenaline. Adrenaline will work on alpha receptors which is there in our peripheral vessels. So because of alpha receptor, there will be vasoconstriction. Whenever there is vasoconstriction, there is reduction in blood flow. So our PET machine will detect airflow in peripheral artery in this finger. Okay. So PET signal is measure of blood volume in the digit after respiratory event termination. Right? When there is apnea, there is fall in oxygen saturation, either 3% or 4%. And because of adrenal rush, there's increased heart rate. So three things happening when apnea is there. There is reduction in blood flow because of sympathetic activity. There is increased heart rate because of sympathetic activity. There is low saturation because of apnea. Okay, so it measuring respiratory event, but it cannot differentiate between apnea and hypopnea because we cannot measure airflow exactly. Okay, so instead of using AHI, we should use REI, respiratory event index, because we don't know hypopnea or apnea. Okay, or PEHI, P means PET, peripheral artery tonometry, PET EHI. Okay, so it also we can say PRDI because low PET signal plus less desaturation. So this is the principle for watch PET. So in this graph, you can see beautifully there is normal PET signal. You can see PET signal. When there is reduction in PET signal, you can see there is reduction in PET amplitude. You can see PET, and along with decrease in PET, there is increased heart rate, there is desaturation, and there is presence of chest movement. This is obstructive apnea. This is normal again. Again, there is reduction in PET flow, increased heart rate, less saturation, chest movement. This is obstructive events. In this, you can see when there is less PET reduction, there is low PET amplitude, increased heart rate, less desaturation, but there is no respiratory movement. Absence of respiratory movement is central event. So it can detect obstructive apnea versus central apnea, right? Another device is actigraphy. This is looks like a watch, our watch. Okay, so this watch detect movement. When you are doing movement, it will tell you that you are awake. When there is complete reduction in movement, it will tell that patient has slept. Okay, so this is like a sleep diary. It will tell you about sleep wake pattern, when you are sleeping, when you are getting up at night, how many times you got up, because it measure movement. Okay, so by this it will tell about total sleep time, sleep latency, wake time. In night, how many times you woke up, like VESU, wake after sleep onset. Okay, so it is good for insomnia and circadian rhythm sleep wake disorder. It's like a sleep diary. Okay, but it's not we wear for one day. We have to use for at least for 72 hours to 14 days. Then only it will tell you correct data. Okay, so in this chart you can see there is black things. This is movement. So whenever there is movement, it will tell you are awake. When there is less movement or lost movement, it will tell you are sleep. Night, again slept, again movement, awake, then again slept. This is Saturday, this is Sunday, this is Monday. So this is like a sleep diary. So it is very useful for to maintain uh, sleep diary. Okay, so what is American Academy of Sleep Medicine says that we can use this for to diagnose insomnia disorder. This is conditional recommendation. We can use for circadian rhythm sleep wake disorder. We can use along with home sleep apnea testing to estimate total sleep time, because it will tell total sleep time. Okay, we can use along with multiple sleep latency test, because in MSLT we need to find that whether patient was slept adequately or not on that previous night. So by this watch we can identify that patient has slept or not before MSLT. So if you combine this actigraphy along with watch PET, so watch PET is what telling apnea, hypopnea, and oxygen. If you combine with actigraphy, it will tell about total sleep time also. So if you find total sleep time, you can identify EHI correctly. Okay, so it can identify REM sleep also, deep sleep also. How to identify REM sleep? Because whenever there is less movement, but there is more variability in pulse rate. So pulse rate more variable. So it tell us REM sleep. This is only estimation. This is not confirmed. Okay. So this is how we can give report with watchpad with actigraphy. So it will tell AHI in REM sleep, in non-REM sleep. This is total. It will tell about oxygen desaturation. It will tell about how much patient went in supine position, prone position, right position, what was the AHI. So it can give complete report of sleep study if you combine these two devices, watchpad and actigraphy, right? These are the very small devices like a button. So this is a one sleep test, or called night owl. This is button like, so we can tie on this fingertip. Again, this also work on the principle of peripheral arterial tonometry. So whenever there is apnea, there will be sympathetic surge, there will be vasoconstriction, it will detect airflow, blood flow, it will detect pulse rate. So this is very good tool for screening. But multiple studies has been done which compare with polysomnography, and there are good studies, there were good data by which they have compared PSG with this device, and based on this study, US FDA approved this for diagnosis purpose. But as of now, we can use for screening purpose only, because we cannot diagnose 100%. So as of now, we can use for screening purpose. So like this machine, so we can this machine can tell you that AHI, oxygen, but work on peripheral arterial tonometry principle. So like this machine, there is another very small machine, Aura ring. This is non-disposable. That was disposable. This is non-disposable. This is balloon ring. So this is like a ring in index finger. So again, principle is same. It's not disposable. And again, approved by US FDA for screening of. And these are the common watch. This is Apple Watch. So in COVID time, it become very popular. Okay. So if you notice that these type of smart watches not only tell about pulse rate and oxygen saturation, it will tell about sleep also, work as a actigraphy also. So it work on principle of actigraphy, which will tell about total sleep time when patients went on sleep, when patient got awake. It will tell about heart rate variability. It will tell about saturation, and also estimate respiratory rate estimation. So this is very good tool for sleep study screening, for OSA screening. This watch will tell that you have problem, you have pulse rate variability, you are having more night awakening, you have low saturation. So in such type of patient, we should do sleep study. So this is very good screening tool. So like this is Samsung watch. So all features are same as Apple Watch, but there are new devices, new Samsung watch. There is another application which will tell about snoring. So this is application is mobile phone. So if you switch on this mobile phone and you kept beside you, it will record your snoring also. So along with these data, actigraphy, heart rate, saturation, it will tell whether you are snore or not. So these are very good screening tool. So coming to my last part, question. So case one, who is he? So I think everybody knows. He is Adnan Sami. He is a very good singer. So as you know, he is very obese person. So since he was obese, he was having snoring, daytime sleepiness, which is suggestive of obstructive sleep apnea. When we screened, not we, but somebody have screened, it was having stop bang of 7/8. He was having diabetes, hypertension. So my question to you is whether he required sleep study or not. If required, which type of sleep study? Okay. So this person having comorbidities, so definitely he required type 1 study only. So when somebody did type 1 study, he was having AHI of 86. This is not real. This is hypothetical. He is severe OSA. So as you know, he used BiPAP and he underwent bariatric surgery for weight reduction. So after bariatric surgery and BiPAP, his he looks like this one. This is complete transformation. He was obese and he was smart guy now. Okay. So my question to you is whether he required repeat sleep study or not. Okay. So answer is yes, definitely. As I told you earlier, that American Academy of Sleep Medicine recommend if some patient lost 10% weight or gained 10% weight, we have to repeat polysomnography to say actual AHI. And post-operative also 3 to 6 months we have to repeat sleep study to say how much effective the surgery was. Okay. So case 2, he is village people, village man, 70-year-old male, no symptom of OSA, but he was smoker and he developed COPD. Along with COPD, he was having hypertension also. When we did ABG, it was having PCO2 of 56. That is hypoventilation. So diagnosis was COPD, hypertension with chronic hypoventilation. So my question to you, whether he required sleep study or not for OSA and hypoventilation? If yes, which type of study? So answer is no. He doesn't require any sleep study. Why? As I told you, if patient is having comorbidity along with symptoms suggestive of OSA, then only you should advise sleep study. So this gentleman doesn't have any symptom related to OSA. He was having hypoventilation due to COPD. So this patient doesn't require sleep study, right? I think I am clear. So this young boy, this is not young, 35-year-old male with high BMI, obese person. But luckily, he doesn't have any symptom of OS. He doesn't have any daytime sleepiness or anything. But serum bicarb was 31. There's no comorbidities. Lucky guy. Okay. So what is the probable diagnosis? So obviously he was obese. He was having he was having feature sensitive of hypoventilation, because if bicarbonate is more than 27, it means it is suggestive of hypoventilation. Okay, so this patient is having obesity hypoventilation syndrome. So my next question to you is whether he required sleep study or not. If required, which type of sleep study? Okay, so in this patient, since there is no comorbidity, this is obese, high probability of OSA, then we can do either type 1 or type 3. Any type of study we can do. And why to do sleep study? Because 90% of obesity hypoventilation syndrome patient, they have OSA. If they have OSA, then they can be treated by CPAP or BiPAP. So we have to diagnose by sleep study. So we have to do sleep study. Now this is case 4 I have shown you. So this man have comorbidities, road traffic accident, symptoms suggestive of OSA. Definitely, this patient is suspicious of OSA. We have to do type 1 study only. I should not repeat again that any patient, those who have symptoms suggestive of OSA, along with comorbidity, do only type 1 study, none other than this. Now, my this is last case, and I hope everybody must have seen Ramayana, at least this man. So this is, who is he? He is Kumbhkarna. Okay, so he was having cuts that he will sleep for 6 months, and another 6 months he will enjoy. Okay, so you must have seen that while sleeping he was having snoring. Okay, so there was no daytime symptom because he was sleeping 6 months. 6 months was he was wide awake. He was doing everything. He was very happy while he is in awake state. So he was having no daytime symptom. Only symptom is snoring while sleeping. His serum bicarbonate is normal. We are assuming, we don't know what's the bicarb. We are assuming that bicarb was normal. There's no hypoventilation. So my question is that does he require sleep study? My question to you is, okay. So my honest answer is I don't know, because if we go theoretically, then you apply stop bank criteria. If you apply stop bank criteria, he was having snoring, yes. He was having high BMI, yes. He was age, yes. He was having neck circumference more than 40, yes. He was having gender of male, yes. So you have a high probability of AOC. So if you go theoretically, you will do polysomnography, but practically he was having no symptom of OSA. He was having no comorbidity. He was happy like a normal person. Then you should not do sleep study. Okay. So this is my honest answer for you. If you want to do study, you can do any study, type 1 or type 3, because there is no comorbidity. So you no need to do type 1. You can do type 3 also. So, to summarize, indication of sleep study, I told you that sleep breathing disorder, complicated parasomnias, before surgery, repeat sleep study, 10% weight loss or gain, after surgery, dental appliances, type 1 studies when patients having comorbidity, split night study, titration study, parasomnias, home sleep testing, comfortable, but we have to do for moderate to severe OSA only. Type 4 like actigraphy, smartphone, Apple phone for screening purpose only, for not for diagnosis. Okay, so these are the my another videos on sleep medicine, like management in simple language for patient purpose also, sleep study titration, how to do, how to interpret sleep report. So all these I have made video, you can check on my YouTube video. So if you like this video, then please share with your friends, and if you are not subscribed this channel, please subscribe it. I am making video in both language, Hindi and English. So whichever language comfortable for you, you can search on my YouTube channel. See you with another video. Thank you very much.